Suppurative lung syndrome. Definition: it's a syndrome characterized by cough and expectoration that's usually excessive, purulent, paroxysmal, and related to posture. It includes bronchiectasis, lung abscess, infected cystic lung, and empyema with bronchopleural fistula. Bronchiectasis. Definition: persistent dilatation of the terminal bronchi. Bronchi and bronchioles normally become narrower as they go distally. If they maintain the same caliber or dilate as they go distally, this condition is called bronchiectasis. Etiology: obstruction leads to infection, leads to bronchiectasis, or obstruction leads to bronchiectasis, or infection leads to bronchiectasis. Obstruction: congenital and acquired. Congenital: immotile cilia syndrome, bronchiectasis, infertility, and sinusitis, or Cartagner's syndrome, dextrocardia, bronchiectasis, and sinusitis. Acquired: from inside, foreign body aspiration, from the wall, chronic bronchitis, from outside, lymph node and tumor compression. Infection: congenital and acquired. Congenital hypogammaglobulinemia, recurrent infections. Acquired: TB and pneumonia. Pathogenesis: pulmonary infections destroy the bronchial wall and dilatation, bronchial obstruction, collapse, and secondary infection leading to bronchial dilatation. Pathology: bilateral, basal, patchy, tubular, fusiform, secular, varicose or tortuous. Inside the lumen there's pus and outside there's fibrosis. Clinical picture: symptoms: suppurative syndrome, excessive sputum more than 100 milliliters per day, fetid, purulent, paroxysmal, winter exacerbation. Positional: increases on leaning forwards. Hemoptysis due to mucosal ulceration. It's a common symptom and may be missile in advanced cases. Bronchiectasis secca hemorrhagica. Hemoptysis not associated with suppuration, dry form, when the involved area is limited to the upper lobes, for example in post-TB and Friedlander pneumonia. General: fahem, fever, headache, malaise, anorexia, cough, dyspnea, chest pain due to pleurisy. Sinusitis may be present in some cases. Signs: general, fever, tachypnea, tachycardia, plus puffy eyelid, clubbing, lower limb edema. Local: like pneumonia but bilateral, basal, and patchy. Inspection: shape of the chest, bulge in a case of pleural effusion, emphysema, and pneumothorax. Retraction in cases of fibrosis and collapse. Respiratory movement diminished on the affected side. Palpation: trachea shifted to the opposite side from pleural effusion, shifted to the same side in fibrosis and collapse. Tactile vocal phrenesis increased on the basal part, decreased in the upper lung zone due to compensatory emphysema. Percussion: dullness on the affected side, bilateral and basal. Hyperresonance in the upper lung zone, compensatory emphysema. Auscultation: bronchial breath sound. Additional sounds: inspiratory crepitations at the affected sound. Pleural rub in case of pleurisy. Complications: general, septicemia, DIC, meningitis, multiple organ failure, amyloidosis, pleural, pleurisy, empyema, and pleural effusion. Then we have the lung: pneumonia and lung abscess, fibrosis, acute respiratory distress syndrome, respiratory failure and cor pulmonale in late stages of the disease. Investigations: radiology, chest X-ray may be normal. Specific finding: honeycomb appearance, soup bubble appearance in cystic type, two-spaced appearance if the dilated bronchi are filled with secretions, tram-line appearance, inflamed, dilated but evacuated bronchi. Radiological signs of complications: pneumonia, lung abscess, trachea shifted to the same side in a case of fibrosis. CT chest, high sensitivity and specificity, and diagnosis of bronchiectasis. Sputum examination, culture and sensitivity test, microscopic analysis to determine if the infection originates in the upper airways or the lower airways. Invasive method: bronchoscopy and bronchography. Bronchoscopy assessing the cause and the site of hemoptysis. Bronchography replaced by CT scan. Blood examination, leukocytosis. Pulmonary function tests may reveal obstruction or restriction. Other investigations: ECG, dextrocardia and Cartagner syndrome, hypogammaglobulinemia. Investigations for immotile cilia syndrome, biopsies from testis and bronchial mucosa or sweat test. Plain X-ray, nasal sinuses, sinusitis, or absent frontal sinuses. Differential diagnosis: other causes of suppurative lung diseases and other causes of hemoptysis. Treatment: prophylactic treatment of pneumonia or other chest infections as early as possible. Therapeutic, medical. The main line of treatment: antibiotics according to the culture and sensitivity. Postural drainage, very important in management of bronchiectasis. Bronchodilators may be needed in cases of wheezes. Symptomatic treatment, deodorant, expectorant, treatment of complications. Homeostatic drugs in cases of hemoptysis. Diet, high-protein diet. Embolic therapy indicated in cases of massive hemoptysis to control bleeding. It's done by injecting sclerosing material in the feeding bronchial artery by aortic catheterization. Surgical, lobectomy or segmentectomy, indicated in localized lesions with severe symptoms as massive hemoptysis. Lung abscess definition. Lung abscess is localized area within the lung parenchyma in which the infection in by pyrogenic organism results in necrosis, suppuration, and cavity formation. Etiology: primary aspiration lung abscess and secondary lung abscess. Primary aspiration lung abscess, aspiration of an infected material from the oropharynx, is the most common cause. Absent cough reflex, decreased conscious level such as coma, epileptic fits, anesthesia. Defective swallowing, bulbar palsy, postoperative, and reflux. Secondary lung abscess, pre-existing lung disease, pneumonia, especially Staph aureus, Klebsiella, Pseudomonas anaerobes, bronchiectasis, bronchogenic carcinoma, subdiaphragmatic amoebic liver abscess in the right lung, hematological spread from intra or extrathoracic sites, pathogenesis, mnemonic stage of acute abscess, and stage of chronic abscess. Mnemonic stage, aspiration of infected oropharyngeal contents, initially leads to pneumonia in dependent lung zones. The right lung is more affected than the left because its bronchus is wider than the left and in line with the trachea. Stage of acute abscess, small zones of necrosis and microabscesses coalesce to form single or sometimes multiple areas of suppuration, and when they reach size more than 1 centimeter in diameter, they are called lung abscess, leaving cavity with irregular thin wall which discharges into adjacent bronchus, and so part of suppuration is expectorated. Stage of chronic abscess, more than 6 weeks of proper treatment without healing, cavity with regular and thick walls surrounded by fibrosis. The inner surface is covered with epithelial growths from the adjacent bronchus. Clinical picture: stage of pneumonia, stage of acute abscess, and stage of chronic abscess. Stage of pneumonia, as explained in pneumonia. Stage of acute abscess, after about 1 to 2 weeks. Symptoms: scheme plus suppurative syndrome plus hemoptysis, fever with rigors, headache, malaise, anorexia. Suppurative syndrome, cough and expectoration of excessive sputum, more than 100 milliliters per day. Fetid urine, paroxysmal, positional, increased in left lateral position, healthy side. Hemoptysis may occur and may be massive. Cough, dyspnea, chest pain, may be dull, aching, or pleuritic pain due to pleurisy. Signs: general signs, fever, tachycardia, tachypnea. Local signs: signs of cavity, no signs in deep or small abscess, the same as pneumonia, plus post-tussive suction in a case of acute abscess. Stage of chronic lung abscess, symptoms: deterioration of general health, loss of weight, anemia and clubbing, suppurative syndrome, retention syndrome, periods of no or mild expectoration with severe general manifestations, FAHM. Signs of cavity plus fibrosis, unilateral chest retraction, trachea may be shifted to the same side. Complications, same as scheme: general, septicemia, DIC, meningitis, multiple organ failure, amyloidosis, and DIC. Pleural, pleurisy, pleural effusion, pneumothorax, empyema with or without bronchopleural fistula. Lung, local, spread to the same or to the other lung, bronchiectasis, pneumonia, fibrosis, acute respiratory distress syndrome. Investigations: radiology, chest x-ray. Specific finding: dense shadow is the initial finding before rupture. Cavity with fluid level, the wall is thin in acute abscess, thick in chronic. Radiological signs of complications: pneumonia, pleural effusion. Trachea shifted to the same side in cases of fibrosis, chronic abscess. CT chest, sputum examination, culture and sensitivity test, microscopic analysis to determine if the infection originates in the upper or lower airways. Bronchoscopy, diagnostic to exclude malignancy, foreign body. Therapeutic, aspiration of secretion, installation of antibiotic, foreign body extraction. Blood examination, leukocytosis and anemia. Differential diagnosis from other causes of cavitary or suppurative syndrome. Treatment: prophylactic, treatment of pneumonia or other chest infections as early as possible. Therapeutic, medical, the main line of treatment. Antibiotics, combined antibiotics to cover gram-positive and gram-negative and anaerobes. Penicillin G or third-generation cephalosporins to affect gram-positive organisms. Aminoglycosides to affect gram-negative, and metronidazole to affect the anaerobic organisms. Postural drainage, very important in management of lung abscess. Bronchoscopy, aspiration of secretion, installation of antibiotic, foreign body extraction. Symptomatic treatment: homeostatic drugs in cases of hemoptysis, analgesia for pain, deodorants, expectorants, treatment of complications. Diet, good nutrition with high protein diet. Chronic lung abscess, continue the medical treatment with another 6 weeks. Surgical treatment is indicated in severe hemoptysis and failed medical treatment. Infected cystic lung or infected bronchial cyst. Definition: developmental anomaly of the bronchial tree with abnormally dilated bronchial wall caliber with bronchial cyst formation. Types: central congenital cyst and peripheral congenital cyst. The central, usually solitary, with no connection with the bronchial tree, whereas the peripheral is multiple, connected with the bronchial tree. Clinical picture: age, usually child, sometimes adulthood, asymptomatic if no infection and no connection with the bronchial tree, the central type. Symptoms, signs, and complications similar to those found with lung abscess or bronchiectasis. Investigations: CT chest, chest X-ray, soup bubble appearance, sputum examination, culture and sensitivity. Treatment: medical, antibiotics and postural drainage. Surgical in single central cyst or localized peripheral cysts. Then we have empyema with bronchopleural fistula. Definition: infected pleural fluid with fistula between the pleural space and bronchial tree. Causes: trauma, rupture of lung abscess into pleural space, direct spread from adjacent pneumonia, and finally invasion of the subphrenic abscess, amoebic liver abscess. Clinical picture of the cause: pneumonia of empyema, pus in pleura, suppurative syndrome. Investigations: chest X-ray, hydropneumothorax, CT chest, pleural aspiration, foul smelling, culture and sensitivity, low pH less than 7.2, white cells more than 15,000 per millimeter cube, methylene blue test, injection of methylene blue into pleural space, bluish coloration of the sputum. Treatment: antibiotics, intercostal tube drainage, and finally surgical pleuropneumonectomy. Acute bronchitis, tracheitis, and tracheobronchitis. Inflammation due to infection can occur in any part of the tracheobronchial tree. It's termed tracheitis, tracheobronchitis, or bronchitis depending on the site. It usually follows viral infections, especially of the common cold type, and is a commoner during influenza epidemics. Secondary bacterial infection is common with H. influenza and S. pneumonia. Clinical picture: productive cough, small volume streaky hemoptysis and fever. Breathlessness and hypoxia are uncommon unless there is coexisting cardiorespiratory disease or concomitant pneumonia. Retrosternal chest pain is common in tracheitis. Examination is normal. There may be low-pitched wheeze and coarse crepitations change with cough. They are due to secretions. Diagnosis, usually on the basis of history. Persistent cough, especially in smoker, may warrant further investigations. Treatment is usually symptomatic, particularly in the previously well-being. Use antibiotics for persistent cough productive of mucopurulent sputum or if there is coexistent cardiopulmonary diseases. And this concludes the chest.